Assalamu alaikum. Thank you very much for this introduction. It gives me a great pleasure to be here with you, even virtually, in the annual Congress of the Saudi Society of Medical Microbiology and Infectious Diseases.
My talk today is going to be about COVID-19, where we stand a transition from the pandemic to epidemic. Here's my disclaimers. Starting with an outline, the talk is going to be about COVID-19 landscape and unmet disease course and potential complications, patient journey, testing and treatments, risk factors for severe COVID-19 disease, nirmatrelvir or Paxlovid, taking into account viral molecular targets, clinical considerations, EPIC-HR clinical trial, and the real-world experience. Starting with COVID-19 landscape and unmet needs from epidemiological standpoint, it is very clear to most of the audience that COVID-19 had a large scale of a problem in different aspects. COVID-19 led to 760 million cases and over 6.5 million deaths globally since the pandemic had begun, and Omicron until April 2023 accounted for over 90% of the cases in North America, Europe, and numerous countries in Latin America, as well as the Asian regions, including our regions. Now, until the fourth quarter of 2022, hospitalizations due to COVID-19 remained high in Europe. Most drastic economic crisis were in the European Union history was because of COVID-19, and I think this was a worldwide economic sequelae to that pandemic that we're facing until today. As of March 23, 2023, Omicron, specifically the lineage of XBB.1.5, is the most prevalent variant worldwide. If we look at influenza and what efforts are being made every year to tackle influenza morbidity and mortality, look at these graphs and tables showing you the comparison of mortality and morbidity of COVID-19 compared to that of influenza, when it clearly shows that those of COVID-19 way surpass the negative sequelae of influenza in number of cases as well as mortalities. As of April 2023, 70% of the world population had received at least one dose of COVID-19 vaccine. Despite this, COVID-19 is still recognized as an enduring health issue. Here are some concerns about vaccines and the pandemic. Vaccine hesitancy, breakthrough infections, waning immunity that is maybe expected to a lot of recipients of any new variants coming along, as well as transmission. Improvements to other aspects of management can supplement. There are methods for preventing an infection, including preventing transmission, perhaps post-exposure prophylaxis, although despite the treatment offering protection against previous variants, no treatment is recommended for Omicron to serve that purpose. But there are approaches to COVID-19 management, including rapid testing and diagnostics, which allow early intervention, and importantly, an outpatient treatment options that can provide easily administered treatment in outpatient setting and prevent complications of COVID disease. COVID-19 disease course and potential complications. This is the disease course and symptomatology, something a lot of us is already familiar with. There is the viral replication, followed by early infection with potential symptoms, typically of upper respiratory tract infection-like illness. But there could be
activation of the host immune response beyond the simple contained upper respiratory tract infection, leading to pulmonary disease with potential symptoms of shortness of breath, with or without hypoxemia. And then a subtype of these patients may go into hyperinflammation phase or cytokine storm, as we had been referring to, and then leading to SIRS, ARDS, shock state, cardiac failure, and even multi-organ failure. The median time to severe COVID-19 disease is 8 days from symptom onset. And if you look, this is a corresponding viral dynamics and immune response to the symptoms that had been shown earlier in the previous slides. Of note, you see the viral genome peaks within 3 to 4 days, and subsequently the immune system will try to build up antibodies and trying to contain the disease. If not, there may be a dysregulated inflammatory response leading to the severe illness or the critical illness with all described cytokine storm clinical manifestations. Here are the possible COVID-19 patient journey, either hospitalization or no hospitalization. On top, for non-hospitalized patients, they either go through simple recovery, some of which may go into long COVID. Among the hospitalized patients, some of which may have moderate disease and they resolve it, or they may end up being in the ICU, requiring sometimes mechanical ventilation. Out of that, mortality may occur, or some may be discharged. Among those who are discharged, are still prone to get long COVID. Below are certain risk factors associated with severe illness, like we will be talking about in the subsequent slides. Here's the COVID-19 disease course. 23 to 34% will go asymptomatic. Around 15% will require hospital admission. Around 5% will require ICU admission with whatever it takes of mechanical ventilation and ventilator support. On the other hand, there are some clinical effects of long COVID with Omicron, including fatigue, dyspnea, hypomnesia, insomnia, chest tightness, muscle and joint pain, and anxiety. COVID-19 can lead to several clinical complications. Here's a selection of complications that may occur, including acute kidney failure, acute liver injury, long COVID, cytokine storm, neuro complications, thrombosis, sepsis and septic shock, etc., etc. You could see how many of complications COVID-19 can lead to. As a matter of fact, it can be affecting every possible organ within the body. So as far as COVID-19 immunity and reinfection and breakthrough infection, around 13% reinfection rate with Omicron has been occurring. There are factors that are affecting the risk for that reinfection to occur, one of which are the new variants, which are very transmissible. Some ethnic groups, especially the non-white ethnicities, people with asthma and nicotine dependence or tobacco use are more prone to get reinfection or breakthrough infection. So as you could probably know by now that prior infection with SARS-CoV-2 or vaccination does not completely preclude new infections. Patient journey testing and treatment. Patient journey testing and treatment. The most important thing in this slide is for you to comprehend that prior to the symptom onset, this is the time when still the detection is very unlikely. And then it is immediately, just a day before symptoms starts, or in the subsequent 1 or 2 days, this is the time when possibly antigen detection through rapid testing can turn positive if it was to be done at that time. PCR likely to be positive towards the end of week 1 and then throughout week 2 to week 3. And then subsequently by week 4 or week 5, PCR rate is negative. Now, antibodies is something mainly for investigational use, is not of a clinical, immediate clinical significance because we don't follow the antibodies testing to verify infection, and certainly not when it's a breakthrough infection or recurrence. So early diagnosis? So early diagnosis, improved outcome, because symptoms that may occur 2 to 14 days after exposure to the virus leads to high-risk patients can quickly progress to severe disease, underscoring the need for rapid therapeutic interventions. The earlier disease is known, the earlier the intervention, and hopefully avoidance complications.
Now, here are two different diagnostic tools comparing the antigen test and the NAT or the PCR.
So both of which are intended to detect current infection, and the specimens for the antigen test can be nasal and nasopharyngeal swabs. The PCR, in addition, will have more specimens, including oropharyngeal, sputum, and saliva. The analysis site for the antigen can be anywhere: home, hospitals, point of care, labs, polyclinics, but the PCR is likely either point of care in a certain center designated for that or certain hospital laboratories. And then what is being detected through the antigen test, as the name implies, is a SARS-CoV-2 antigens, when the NAT would be looking for the SARS-CoV-2 RNA in particular. Sensitivity for the antigen test varies depending on the cause of the infection, and the PCR vary depending on the specimen, the quality of the PCR kit, as well as the severity of illness and the degree of the or the duration of the disease per se. Specificity very high in both diagnostic tests. Risk factors. So here are the factors that raise the risk of severe disease from COVID-19. The most important risk factor is age. There are different data describing what is the most vulnerable age, but it has been standardized that possibly 50 and above of age brings a very high risk of COVID-19 related complications. Those who are immunocompromised or taking medication that suppress the immunity, those who have underlying health conditions or comorbidities, pregnant women or recent pregnancy, as well as racial or some ethnic minorities had been shown to have vulnerability to severe illness from COVID-19. So these are the European CDC risk factors for provision of severe COVID-19. They don't differ from the American, except that the American list is more extensive, and so I would prefer to describe that with some details in the next slide. Here you see the CDC systemic review process that has identified certain underlying medical conditions that can increase the risk of severe COVID-19. They have been categorized into higher risk, which means there is a conclusive evidence that these long list, two lists of risk factors that you see, including asthma, cancer, cerebrovascular disease, chronic kidney disease, chronic liver disease, chronic lung disease, cystic fibrosis, diabetes of the two types, disabilities, including Down syndrome, heart conditions with a variety of them, HIV, mental health conditions, neurological conditions, some physical inactivity, obesity, pregnancy, primary insufficiencies, smoking, solid organ or blood stem cell transplantation, TB, and the use of steroids and other immunosuppressive agents had been conclusively thought to be predisposing to severe COVID-19 if patients were to acquire a new infection. There are some which are suggestive higher risk, which you see in the third column, and those with mixed evidence of evidence towards severe infection is what you see in the far right. Why is it so important to categorize patients this way? Because our intervention with early COVID-19 will depend on the presence of these risk factors and deciding based on those to administer early COVID treatment. So risk factor for COVID infections, like I said earlier, hospitalization and death are so much associated with age, and then you could see here rates or several folds of death occurred with increments of decades of age to patients. So in this part of the lecture, I will switch gear and talk about molecular targets for certain medication and what is Paxlovid. So evolution of SARS-CoV-2 treatment options had been tackling different sites within the viral replication cycle. There is the binding sites, like the neutralizing monoclonal antibodies or convalescent plasma or plasma-derived therapies or vaccines, or those who are tackle the entry or exit, like human protease inhibitors, or those related to proteolysis, which prevent the formation of proteins involved in viral replication, again, like the protease inhibitors, or the RNA replication, like the RNA polymerase inhibitors, kind of medication. So here are the COVID-19 therapeutic approvals timeline, and you could see since March 2020, when it was declared as pandemic, there has been one medication after the other that are targeting one of the 4 different sites that I have shown you earlier. And then what you could see here is that some of which are no more effective against newer strains, and they have been out of the our arsenal to defeat and our fight against COVID. And then you see what were the remaining, especially among the early treatment options, are nirmatrelvir, ritonavir, or Paxlovid, molnupiravir, and remdesivir. So this is where these different agents are being positioned for the treatment of non-severe COVID-19 within the guidelines. So if I start with nirmatrelvir, ritonavir, the NIH limited as the preferred therapy for non-hospitalized patients. WHO strong recommendation in favor of it. Molnupiravir listed as an alternative therapy as far as NIH, and the MOH gave it a weak or conditional recommendation in favor. Remdesivir, which is administered intravenously, listed as a preferred therapy for non-hospitalized patient and by the NIH, and for the WHO, weak or conditional recommendation in favor of it. And sotrovimab, not listed in recommendations by the NIH, and it is a strong recommendation against as far as WHO is concerned. And then mind that these recommendations are based on the current variant, which is Omicron. So the potential of the IMPRO as a therapeutic target, and then the IMPRO, the main protease, is a suitable target for anti-coronavirus therapies because it's essential for the gene expression and replication. The substrate recognition pocket is highly conserved, and the IMPRO recognition cleavage sequence is not associated with any known human proteases. So here are where you see between, or the central dogma from the SARS-CoV-2 genome into translation, into proteinolysis, and you see where the IMPRO is likely to serve and help in the viral replication process. And then clearly it shows here, had that been eliminated, there is a significant disruption to the viral replication process. So nirmatrelvir has been designed to prevent viral replication by inhibiting the IMPRO of SARS-CoV-2, and it binds to the active site of it and prevent viral replication, which is the most, or one of the most suitable drug targets among coronaviruses. Now, the addition of ritonavir is simply just a PK enhancer for nirmatrelvir. So Paxlovid is nirmatrelvir tablets co-packaged with that of ritonavir tablets to enhance the bioavailability of the novel drug, which is the nirmatrelvir. That is by slowing its metabolism by CYP3A. So nirmatrelvir has demonstrated in vivo activity against SARS-CoV-2 variants of concern, including prior ones like alpha, beta, gamma, delta, and the current one of Omicron. Here are some clinical considerations for Paxlovid. So, Paxlovid is indicated in the Kingdom of Saudi Arabia in adults who do not require supplemental oxygen and who are at increased risk of progressing to severe COVID-19. The recommended dosage is a 300 milligram of nirmatrelvir, that are two 150 milligram tablets with 100 milligram of ritonavir, that is 100 milligram tablet, all taken together orally every 12 hours for 5 days. It's important to know that Paxlovid should be administered as soon as possible after the diagnosis of COVID-19 has been made and within 5 days of symptom onset. It can be taken with or without food, and the tablets should be swallowed in whole and not being chewed, broken, or crushed, as no data is currently available in that regard. For patients requiring hospitalization, completion of the full 5-day treatment course is recommended even if the patient requires hospitalization due to severe or critical COVID after starting treatment with Paxlovid, which means that they, for example, have taken 2 days, they progress to severe disease, the remaining 3 days should be continued. And if there are missed doses, if the patient missed a dose of Paxlovid within 8 hours of the time it is usually taken, then the patient should take it as soon as possible and to resume the normal dosing schedule. Paxlovid use in special populations. As far as renal impairment is concerned, no dose adjustment is required in mild renal disease. In moderate renal disease, it's requiring halving the dose of the nirmatrelvir from 300 to 150, but the ritonavir remains the same, and the frequency remains twice daily, and then it should not be used in patients with severe renal disease, or those who are requiring hemodialysis for end-stage renal disease. As far as hepatic impairment is concerned, no dose adjustment of Paxlovid is needed in patients with mild or moderate hepatic impairment, and it should be avoided in patients with severe hepatic impairment. Now, the concomitant ritonavir or combicistat containing regimens, no dose adjustment of Paxlovid is needed, and patients who are receiving or diagnosed with HIV or hepatitis C infection who are receiving ritonavir or combicistat containing regimen should continue their treatment as indicated. There is no data for safety and efficacy of Paxlovid in pediatric population, those who are below the age of 18, as well as those who are childbearing potential or pregnant or lactating women. Perhaps the most important essential pharmacological information required to be known about Paxlovid is the risk of serious adverse reaction due to drug interactions. Paxlovid has a potential for interaction should be considered with other medical products prior to administering this therapy. And then here in the subsequent slide, I shall describe this in some details. So, because it is known for drug-drug interaction, it has been categorized into different drug categories or different drug interactions categories. Those where there is an increased concentration of co-administered drugs, and here are the list of them. This indicates certain drugs that are likely to increase in its concentration and may lead to certain side effects of those who administer the drugs because their levels are potentiated to a high level. This is a list of the drugs that are expected to have decreased concentration when co-administered with Paxlovid, which means that their effect may be weakened or becomes less, and then it may lead to failure of their effect had they been administered with Paxlovid. And there are certain list of medications which are just considered contraindicated to be given
concurrently with Paxlovid, and they need to be stopped when Paxlovid is given, or perhaps Paxlovid not to be given, and then maybe other anti-COVID-19 early treatment option to be considered. Now, the basic rules to manage a drug-to-drug interaction, because there are many, is to, for example, take this exercise and then to ask several questions. Is the patient receiving any other medical or medicinal products? If there is a contraindication, or do these medications have potential interaction with Paxlovid? There are several ways that drug-to-drug interaction can be elicited, and then in case of significant interaction, there are questions to be asked to consider the safety of administering those two drugs together. Can concomitant medication be temporarily discontinued? This is one way of handling it. Can the dose of the concomitant medication be reduced if there is a potential for it to increase in concentration with Paxlovid? Can the alternative concomitant medication be used altogether, or maybe use something else instead? Can an increased monitoring of adverse events or concomitant medication drug levels be done if that is the case? And if none of these are possible, then just avoid co-administration. If that can be the case, there are many ways to tackle this. And then here is a QR code for the learn more about the drug interaction with Paxlovid, and there are several websites you are welcome to entertain and to educate yourself about in the internet about the common ways of or tactics about handling drug-drug interactions of Paxlovid and other medication had it been necessary to be administered. Okay, let's talk about some clinical trials here, and starting with the EPIC-HR. So the EPIC-HR, which stands for the EPIC for high-risk patients, these are Paxlovid in high-risk unvaccinated populations, and in this trial, it was comparing those high-risk unvaccinated patients, looking at the duration of 24 weeks with the intervention of giving Paxlovid, the dose mentioned, versus placebo among non-vaccinated patients in their early symptoms, and looking at outcome of COVID-19 related hospitalization or death from any cause throughout the first 28 days after administering the drug. Please mind that at the time the EPIC-HR was conducted, it was during the Delta wave worldwide. So the study design is what I've already explained, and the primary endpoint by percentage of patients with COVID-19 related hospitalization or death from any cause throughout day 28. Among patients treated for 3 or less days from onset of COVID-19 signs and symptoms. There were other secondary key endpoints. The first one is when the primary endpoint analyzed primarily among patients treated not less than 3 or equal, but less than 5 or equal days from signs and symptoms of onset. And then the other secondary endpoint was detection and quantification of SARS-CoV-2 viral load in nasopharyngeal swabs by real-time PCR at baseline, day 1 and day 3, 5, 10, and 14. So this secondary endpoint is more of an infection control kind of an objective to assure or to evaluate the effect of the drug in reducing the transmission. So here's the baseline demographics and characteristics, which clearly show that they were balanced between the groups, and they were largely representative of the expected patient population among those patients with COVID-19. And the 61% of patients had two or more characteristics, or comorbidities associated with risk of progression to severe COVID-19 at baseline. The most common were those who are either obese with a high BMI more than or equal to 25, cigarette smoking, hypertension, aged more than 65, or diabetes mellitus, which makes it fairly representative to the most common risk factors that I have already alluded to
leading to or rendering patient vulnerable to severe COVID-19 after the acquisition of the infection. And the primary outcome shows that Paxlovid lowers the risk of progression to severe COVID-19 by 89% compared to placebo, and that is the primary endpoint. The key secondary efficacy showed that Paxlovid efficacy was confirmed in the modified intention to treat 1 population, whereby resulted significantly in fewer hospitalization or deaths by day 28, and this is again after being administered according to protocol.